Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
We emerged from the COVID-19 pandemic in 2022 to headlines about unseasonably early spikes in respiratory syncytial virus and concerns and threats of a triple pandemic of COVID-19, influenza, and RSV. Fortunately, there's been no triple pandemic, but what has emerged is multiple first-time vaccine approvals for RSV. The CDC recently updated its adult recommendations for RSV vaccines, so I invited my Vizient colleague, John Schoen, Senior Manager of Drug Information, to discuss the use of those RSV vaccines. John's visited this podcast on multiple occasions, most recently last year discussing nirsevimab for prevention of RSV lower respiratory tract disease in infants and children. I'm Stacy Lauderdale, Associate Vice President of Evidence-Based Medicine here at Vizient and your program host. John, welcome back to the Verified RX podcast. I know it's been a while, so why don't you reintroduce yourself to our listeners?
Thanks, Stacy. I'm glad to be back. I'm John Schoen. I'm a Senior Clinical Manager of Evidence-Based Medicine and Drug Information within the Center for Pharmacy Practice Excellence at Vizient. My background's in drug information. Prior to joining Vizient, I worked at a large academic medical center for about 6.5 years, where I served as a drug policy and formulary management pharmacist. In my role at Vizient, my focus is primarily on preparing and developing member-facing written deliverables with an emphasis around evidence-based medicine. And one of my clinical areas of focus is infectious disease, and I serve as the lead for the various clinical vaccine deliverables produced by the Center for Pharmacy Practice Excellence team.
Well, thanks, John. We're excited to have you on the podcast. So today we're going to be talking about RSV vaccines in older adults. Now, when I think about RSV, I think about pediatrics. I would assume that most of our listeners are pretty well versed about RSV in pediatric patients. What is less well known is the disease burden in older adults. Would you share with our listeners the RSV disease burden in older adults and what puts you at risk for severe illness with RSV? Because for most adults, I'm assuming it's just a cold.
What you said and what you identified are really the two highest risk populations in general, which include the very young infants and children under the age of 2 with risk factors, as well as the older adults. Within older adults, lower respiratory tract disease is commonly caused by RSV. It's one of the respiratory pathogens that circulates during the winter season, typically around October through March. And risk factors for severe disease include increasing age, as well as a variety of medical conditions. These things include lung disease, heart disease, those who are immunocompromised, and a variety of other chronic medical-related conditions. Today, we're talking about specifically the vaccines in the older adult population. Depending on the data you look at, in the US, for those 65 and older, the general estimates of RSV disease or lower respiratory tract disease causing hospitalizations is around 60 to 160,000 hospitalizations and approximately 6,000 to 10,000 deaths in the year due to RSV.
So you just quoted some impressive numbers around hospitalizations and deaths. It would help even more if we could put it in perspective in comparison to influenza impact. As a healthcare provider, every season, we certainly place a lot of emphasis on our influenza vaccine campaign. As we think about the upcoming RSV vaccine campaign, it's important to understand the relative disease severity of RSV versus influenza.
The data that we have in terms of actual numbers of hospitalizations and deaths for influenza, the most recent data is from the 2022-2023 season. Just for the sake of consistency, looking at the adults 65 and older, during that season, there were over 190,000 hospitalizations and over 15,000 deaths related to influenza, which are both greater than the high-end estimates for RSV. In terms of hospitalization rates, we do have a little bit more recent data for the past 2023-2024 season. These hospitalization rates are cumulative hospitalization rates reported per 100,000 people over the age of 65. For flu, that rate is 221 approximately, and for RSV, it's around 106. And just for some additional context, COVID-19, that rate of hospitalization per 100,000 people is 547. Out of the three respiratory pathogens of primary interest, RSV has the lowest rates of hospitalization compared to flu and COVID.
Thank you so much for providing that context. It's really helpful. Let's get into the vaccines that were available last year. We had GlaxoSmithKline's Arixvi RSV vaccine approved, and we had Pfizer's Abrysvo vaccine approved as well. What can you share with our listeners about vaccine uptake during the last RSV season? If we had any early outcome data around the RSV vaccination campaign in older adults?
The CDC has data around vaccine uptake. This data is for specifically those 60 and older, and that is the population that all three of the RSV vaccines are approved in. So for the 2023-2024 season, this data goes through May of 2024. Approximately 24% of that population received the RSV or the Abrysvo vaccine. If you look at that compared with COVID vaccination rates and flu vaccination rates, it's definitely lower than both of those. In the same population, 60 and older, 37% of patients received the updated 2023-2024 COVID vaccine, and then 69% of that population received the flu vaccine in the last season. As far as outcomes, we do have some observational data looking at RSV-associated hospitalizations for 2023 and 2024 in the 60 and up population. This data is coming from the Veterans Health Administration and was shared at the June ACIP meeting. They looked at a couple different outcomes, but as far as just RSV infection goes, just any sort of symptomatic infection, they found that the vaccine efficacy was around 77%. And then for hospitalizations, it was at 82%. There are limitations as it is observational data. And given that the data set is coming from the VHA, these are older patients that are more likely to have chronic risk conditions, potentially patients that would be at higher risk for more severe disease that might lead to a hospitalization. The vaccine uptake overall in this population was relatively lower than what we saw in the general US adult population. It was 5 to 10% compared with that 24% that we saw in the overall adult population over 60 in the last season. There's some potential bias that could be introduced with a lower vaccination rate. Those who are specifically vaccinated may have differences in risk-seeking behavior or may be more likely to go seek out medical care compared with a non-vaccinated group. All that to say is that this is the data we have. It's observational, but based on that data, the vaccines seem to have prevented some important outcomes, but certainly comes with limitations.
It sounds like we had a greater or a more at-risk population in that observational data set. How did the point estimate of the observational data compare to what we saw in the clinical trials? Was it similar? Was it more efficacious in the observational, less efficacious?
The clinical trials looked at different endpoints than what is being reported in those observational data sets. The clinical trials for all three vaccines looked at lower respiratory tract disease due to RSV. That doesn't necessarily mean that it was hospitalization. It is more severe on the spectrum of upper respiratory versus lower respiratory, and they had differing definitions across the trials. Overall, if you look at that primary endpoint for the lower respiratory tract disease, it is very similar to the point estimate of hospitalization that was seen in the observational data. But what's interesting is the actual number of hospitalizations that was seen in the randomized controlled trials was very low. It wasn't included as a specific endpoint within that lower respiratory tract disease. A few of the trials did look at severe disease, but most of them didn't have enough endpoints to report out on that outcome. And in the trial with RSV specifically, they did report out on their number of hospitalizations in over 2 seasons. There were, I believe, 1 hospitalization in the vaccine group and 5 in the control group out of about 25,000 patients. So very low hospitalization rates in the randomized controlled trial data. It's interesting that the point estimates in the observational data set for hospitalizations were the same as just lower respiratory tract disease in general with that randomized controlled trial data.
That is very interesting. There's certainly been changes in the RSV vaccine space. And that's why we wanted to have you on the podcast today, is to talk through those changes. One of the changes in ACIP recommendations, and those changes reflect our understanding that this vaccine may be more efficacious in those that are higher risk. Talk us through the ACIP recommendations, as well as that there was an additional RSV vaccine that's now available.
Before I get into that, I just want to give a brief recap of where we were coming into this year as far as RSV vaccines are concerned. Last year, we had our first 2 RSV vaccines that were ever approved, which include Abrysvo and RSV, as well as the ACIP recommendations for the use of those vaccines. Abrysvo is recommended in those 60 and up, as well as for maternal use to prevent lower respiratory tract disease due to RSV in infants. And then RSV was originally approved for 60 and up as well. ACIP last year voted on the recommendation for the use of these RSV vaccines via shared clinical decision-making and those 60 and up. Coming into this year, at the end of May, we had our third RSV vaccine approved, which was Mrezvia from Moderna, the first mRNA vaccine compared with the other 2, which are more conventional vaccine platforms. In June of this year, RSV also had its indications expanded to include a population that's 50 to 59 years of age at increased risk for disease. Currently, RSV is the only of the 3 RSV vaccines that has an indication for use in less than 60 in the older adult population. ACIP revised their clinical decision-making recommendation in June. Originally, it was just 60 and up based on shared clinical decision-making. This was changed to a risk-based recommendation in adults 60 to 74 years of age, a flat recommendation for adults 75 and up. This just recognizes that as you get older, the risk increases, particularly in that age group over the age of 75. And with those adults 60 to 74, if you don't have any chronic medical conditions, the data would suggest that your risk is not as high as those individuals who do have conditions like heart disease or diabetes or who are immunocompromised. The vaccine is going to have more of an impact or maybe make more sense for those individuals that have those risk conditions and then as they get older. The other thing with the ACIP recommendations is that even though RSV did get that expanded indication to 50 to 59, ACIP did not feel that they really had the data that was sufficient to move forward with voting on the use of RSV vaccines in that 50 to 59 population who had increased risk factors. So they deferred that. I expect that they might revisit that at the October meeting, but at least for now, the ACIP recommendations are specific to those 60 and up, even though one of the vaccines does have an FDA approval for 50 to 59.
So it sounds like there is a decreased patient population that is now eligible for RSV vaccination during the 2024-2025 RSV season. Prior to the newest ACIP recommendations, ACPI had previously recommended shared clinical decision-making. And now for those patients aged 75 and older, it is a flat recommendation that you should go ahead and get an RSV vaccine. One of the things we experienced after the COVID-19 pandemic is we've had a bit of decreased vaccine confidence. And I absolutely believe one of the ways to increase vaccine confidence is informed discussion between a patient and their provider, whether that provider be a pharmacist or a physician. If someone came to you who was aged 75 and older and asked, what are the potential benefits of RSV vaccination for me? What could we tell that patient?
The move from shared clinical decision-making to risk-based recommendations in that 60 to 74 and that flat recommendation 75 and up, I don't think that that takes away the importance of still having those discussions. At the ACIP meeting, there was quite a bit of discussion around the challenges associated with shared clinical decision-making. These recommendations make it more straightforward, but it's important for healthcare providers to have those discussions with patients and going over the risks versus benefits and talking about what are the potential side effects, what are some of the more rare side effects that we may be concerned about, what are the actual benefits, what does the data show, how many patients need to actually get a vaccine to see a benefit, what does that look like, and have those individualized discussions. That's critical in improving vaccine confidence rather than just saying, this is what the guidelines say, so you need to get this vaccine if you fall into this bucket. Those discussions are important to have with patients so that they understand why the vaccine may be right for them and they can make those informed decisions.
One of the things you mentioned was having a discussion around adverse reactions. What are those potential adverse reactions of RSV vaccines, not only in clinical trials, but observational that we've seen after the first season of vaccination?
In general, all 3 of these vaccines were well tolerated in the clinical trials, and the most common adverse reactions that you see with these vaccines are similar to the adverse reactions that you'd see with any vaccine. Some local injection site reactions, redness, pain at the injection site, maybe some mild systemic adverse reactions. In general, all 3 were pretty well tolerated. An ongoing area of evaluation is around some of the adverse events of special interest, particularly Guillain-Barré syndrome. This is something where in the trial with RSV and Abrysvo, there were cases of Guillain-Barré syndrome reported in both the clinical studies as well as in post-marketing data that we have. And actually, as a part of condition of approval, FDA required that post-marketing studies be conducted for both of these vaccines. However, we will not see the outcomes of that for quite a while, as the completion dates for both studies are estimated to be around 2030. And then for RSV, we did not see any cases of Guillain-Barré syndrome in the clinical studies, but patients have received both RSV and Abrysvo Abrysvo at this point compared with mRESVIA. So it's important to keep an eye on and monitor for all of these vaccines. But certainly the data that we do have with Guillain-Barré syndrome is exclusive to Arexvy and Abrysvo at this time. And Guillain-Barré syndrome is also something that FDA is actively and continuing to monitor. And they shared some data at the most recent ACIP meeting around this. There's no data for mRESVIA at this time based on the observational data given the recent approval of mRESVIA. So it focused specifically on Arexvy and Abrysvo. And they looked at a data set of Medicare beneficiaries and they provided some estimates per 1 million doses of vaccines. That estimate with Arexvy and that self-controlled case series was 3 cases of Guillain-Barré syndrome per 1 million doses. And then Abrysvo is 16 cases per 1 million doses. With the data we do have, the Guillain-Barré risk estimates are based on observational data and overall a relatively small number of events that carry a high degree of uncertainties. We really don't have the sufficient data to provide conclusive evidence of an increased risk to either rule in or rule out. And we also aren't able to really draw definitive conclusions around comparative risks between the vaccines at this point.
What you said there is really important is there's a lot of uncertainty around incidence, not only the absolute incidence of it with each individual vaccine, but also the comparative risks. I certainly heard some patients saying their physicians prefer a certain RSV vaccine over another. I don't know if it's safety related or efficacy related, but what I'm hearing you say, at least from a safety perspective, is we can't make that conclusion right now.
Correct. Even for both an efficacy and a safety perspective, we don't really have the data to make any kind of conclusions on comparative efficacy or comparative safety. In the randomized controlled trials, each of the different vaccines, they did look at that similar endpoint of lower respiratory tract disease due to RSV, but that definition varied slightly from trial to trial. The timing varied a little bit as well as the design. So even though we have the point estimates of vaccine efficacy for those trials, you really can't compare them directly. And same goes with the safety at this point.
Thanks for the answer, John. And I think the reason I ask that is because I want to pivot to providers. It's very unlikely that a provider will carry all 3 RSV vaccines, even if a patient wants a certain one. Are there any operational differences among the 3 vaccines that would make maybe one more preferential versus the others?
There's a few differences between them. I don't know that it would have a huge degree of influence on the selection. The differences are relatively minor in terms of operational and storage and that sort of thing. Arexvy and Abrysvo are both supplied as single-dose vials. Abrysvo comes with either a prefilled syringe or a single-dose vial of sterile water diluent that is used for reconstitution, and Arexvy is supplied with a diluent of adjuvant that is used for reconstitution. So both of those require reconstitution, whereas mRESVIA is supplied as a prefilled syringe, potentially from a convenience standpoint, prefilled syringe might be a little preferential as compared with having to reconstitute out of a single dose vial. But from a storage standpoint, Arexvy and Abrysvo maybe offer the advantage there. They're both stored under refrigeration, whereas mRESVIA is recommended to be stored frozen. However, it may be stored in the fridge for up to 30 days. In terms of just ease of storage, Arexvy and Abrysvo offer a little bit of convenience there. The last thing is really just some minor differences in terms of FDA indications when you're thinking about which of these vaccines would be recommended across different populations. Maybe looking at vaccines that have broader indications might be more applicable to a larger range of patients. Arexvy has that 50 to 59 population, which is unique. However, it's not ACIP recommended in that population yet, but that's the direction we are heading. Abrysvo, Pfizer has submitted for approval in 18 to 59 with a decision date expected in October of this year. And Moderna is looking at mRESVIA in 18 to 59 as well, but that decision is going to be later down the line. Some differences potentially in that under 60 population that are coming. And then the other thing is that Abrysvo uniquely has that maternal indication for preventing lower respiratory tract disease in infants. So maybe another consideration there.
That is true. And glad you brought that up. As providers, we need to be aware of the potential for medication errors. If you do have a pregnant patient administering the wrong RSV vaccine, that may not be indicated for that particular patient population. So John, here's the $1 million question. Are patients going to need more than one RSV vaccine? Because just like influenza, RSV comes around each fall and winter.
That is one of the big questions right now is we don't really know. Currently, everyone that is recommended to get an RSV vaccine is just recommended to get a single dose. But we do have limited data on the long-term efficacy. What we do have right now is efficacy data through 2 seasons. Some of this data is published, some of it's unpublished. But if you look at, just for the sake of consistency, the clinical trials that had endpoints involving 3 or more symptoms and compare the vaccine efficacy in that first season data versus the vaccine efficacy over 2 seasons, across the board, we do see a drop in that vaccine efficacy over that second season. With RSV, the vaccine efficacy was 67.2% compared with 82.6% in that first season. With Abrisvo, it was 81.5% over 2 seasons compared with 85.7% in the first season. And then with Mrezvia, over 2 seasons was 49.9%, down from 82.4% in the first season. I would caution about making any direct comparisons between these. Some of these numbers are quite a bit different than the others, but difference in endpoints, timing, study design, that sort of thing. Broadly speaking, it does appear that the more conventional vaccine platforms have a little bit more of a durable response than what we saw with the mRNA vaccine, but difficult to really make any definitive conclusions on comparative efficacy around those vaccines. We do have ongoing studies to look at the efficacy of these vaccines across further seasons. The other thing that is actively being evaluated for all 3 vaccines are revaccination studies. I suspect, just given that over 2 seasons we saw a drop, some greater than others, with these vaccines, that at some point we probably will see recommendations come out for getting revaccinated, probably in that 3 to 5 year time window. And at this point, everyone's just recommended to get the 1 dose. We'll see what comes in the future with that.
Well, John, I really appreciate you joining us at Verified RX podcast to share your insights around the RSV vaccine. And I hope all the listeners gain some new knowledge to have informed discussions with their patients during the RSV vaccination campaign as well.
Thank you, Stacy.
Listeners, please join us for more Verified RX podcasts. Subscribe today, like us, and send us your comments. We'd love to hear from you. Verified RX is your prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. I'm Gretchen Brummel. Thanks for listening.